Thank you, Vishal, for the introduction. I still say I'm a student of science, not that much of the biodata, but still you're looking very sharp today. So I'll just go. Let us begin from the beginning, and this is our third in a row. And in third, we were to discuss the dental extractions. And I'll start from the basics and begin from the beginning. Let's see the aspects of the teeth in dog and cat. Let's say this is the whole vestibule of the oral cavity when you see from inside. Okay. Now, the teeth, the surface of the teeth which are facing the cheek, they are buccal, right? Those they are facing the lips, they are labial part. Okay. Then those who are facing the palate, that is the palatal surface. Then when you start from here, the teeth, the surface, those are facing the first incisor tooth. It is known as a mesial surface. And just opposite to the mesial surface is the distal surface, right? I'll make it more convenient for you. See, suppose this is a tooth. Let's say it's a canine. Okay. So canine means that B is a buccal surface of the teeth. M is the mesial surface. Opposite to the mesial is a distal surface, and L is a lingual surface. That means this part is facing the tongue, mesial is facing the first incisor, opposite to the mesial is a distal part, and buccal is within the cavity. It is as simple as that. Okay. Why it is important to know the surfaces? Because then we'll be working out accordingly. Okay. Now, when you open up the cavity, you have a tooth. It looks like somewhere like this. Now, where the tooth inserts into the gingiva, that portion is known as root, and the portion of the root is technically known as a radicular portion. Okay. Then the portion around or the tissue around the root is known as the interradicular. That means the portion of the tissue which is between the two roots is known as the interradicular portion. Okay. Now look at this. I'll make it more simple for you. This is a teeth incisor. Okay. Now incisor has a posterior surface here. Okay. It is a posterior surface. So the posterior surface I told you is a distal surface. So we normally call it as a distal buccal line, like distal buccal line. When you talk of premolar 1, this is the proximal part. So proximal part is known as the mesial, right? A mesial surface because it is facing towards the first incisor. So that is the mesiobuccal line of the 205. Okay. Now, when again, let's have a recap of the tooth here. Now, again, this is, I told you in the beginning on the first, that outer part is the enamel. Dentine continues throughout the radicle, I mean the root also and the crown also. Inside is a pulp chamber. Pulp chamber contains the vessels and the nerves. The part which is within the gingiva and in the alveolar socket is known as the root, right? And this portion, I mean this part which you can see is a bit darker, is known as periodontal ligament. This periodontal ligament is responsible for holding the tooth in the alveoli in a very subtle manner. And you can very well imagine that, chewing is a continuous process, and it is no doubt a rigid part, but at the same time, it is elastic also, thus neutralizing various forces acting upon it, right? Now, let us have a magnified view of the periodontal ligament in association with the alveoli, because you are going to work somewhere over here when it comes to the dental extraction. Okay, now here, see. Now, this is the periodontal ligament, this region, right? Can you see this darker portion? This is a cement. From the cement, the fibers of the periodontal ligament, right? They go and they attach to the alveolar bone. So cement, that is the outermost portion of the root, has one insertion of the periodontal ligament, and the second insertion is on the alveolus. So likewise, numerous fibers, they attach the cement with the alveoli, and when it comes to extraction, you have to work upon these areas. I mean, these has to be torn, these are to be damaged in order to loosen the root within the alveolar socket and to take it out, right? Just an overview to see that how close and rigid and a pakka association is there of the PDL with the tooth and the alveolar bone. Okay, just look at those vessels here. Just be careful about the vessels, because these vessels, they are in quite a network. 21% of the supply of whole of the body is directed towards the head. So when head has 21% of the vascular supply, that means it is highly vascular, highly rich in vessels. So bleeding can occur, right? Now, again, a recap. Dental formula in adult dog is total number of teeth. They are 42. The incisors in canine all have one root. Then the first premolar and the lower third molars have one root. The upper second and third premolar and the lower second, third, fourth, second, third, and fourth premolar and first and second premolar have two roots. The upper fourth premolar and first and second molars have three roots. Okay, now how to remember that? Even I don't remember now. Okay, how to remember that? Keep this picture pasted on your wall. Okay, incisors and the canine, one root. I'm talking about the upper jaw here in the canines, right? So all have one root. Then the premolars have two roots. Then premolar 4 and the molars have three roots. When you go down to the lower jaw, all these have one root, right? Premolar second till the molar have two roots, and last molar has one root. True with the feline also. Same way, one root, two root, carnassial has three roots, then last, first molar has, 1 to 3 roots. Then if you talk of lower jaw, one root, two roots. Okay, so when you keep this picture pasted on your OT or on your dental desk, it would be easy for you to find out that and what teeth you are working upon and how many roots are there, because knowing the number of root becomes very important, because then you have to extract a single root by sectioning the tooth. Okay. What are the indications? Why we need the exodontics? Why we need the exodontics? Why need to extract the teeth? So the first most common indication is the periodontally compromised teeth, and a lot of periodontitis is there. The second indication is the severe chronic gingivostomatitis, malformed teeth causing the gingivitis and periodontal disease, luxated or subluxated teeth, retained unerupted teeth, mostly the deciduous teeth, then teeth affected by the odontoclastic resorption in the cats, especially when we talk of the FORL. Just look at this example, teeth. Almost everything of the teeth has gone and the pulp has exposed and it is infected. Then the teeth is fractured here, multiple fractures. This is very common, persistent deciduous canine teeth. You can see extra supernumerary teeth here with the original canine. Then crowded incisors are very common. Can you see this is a normal line here of the incisors, but you have these crowded extra incisors up there. So crowded incisors, that means the extra incisors have to be removed. Then when you take the x-rays, this is the x-ray of the deciduous teeth. This is a original permanent canine, but there is a deciduous teeth which is retained and not been replaced with the age. So this has to be taken out. Okay. Then you have the overcrowding here. Can you see this? Can you see this overcrowding here? Right? Yeah, this one. So this is canine here. This is P1 here, but here is a overcrowding. So this has to be taken out. Then dysplastic root of the right maxillary canine. This is canine. Can you see the canine and the root? And you see this area which is questionable. This is a dysplastic root of the right maxillary canine. Again, a very common finding. In that case also the teeth has to be removed. Can you see this should be a normal here, but it is twisted. This is delacerated root. If we find such kind of deviation on the root, this teeth has to be extracted out. Now, here is a inflammatory tooth resorption. That means type 1 in cats, the dentine and the tooth substance is being eaten up. It is in the process of resorption. Now, this tooth has to be taken out. Fine. Here also, can you see the horizontal and vertical bone loss? And here, the area of radiolucency. That means this periapical lucency indicates that here also and here also, it indicates that there is a pocket of pus or maybe inflammation in the root, and eventually this tooth would become very painful and has to be taken out because it will then start loosening from its socket. Then see, when you talk of the vertical and horizontal bone loss in a dog, so here there is a vertical bone loss, and here you can see this is exposed here. Whole vertical, this is horizontal bone loss, and this one is a vertical bone loss. That means there is a gingival recession. At the same time, there is a bone loss, and the furcation is exposing. And as the furcation is exposing the root, it is getting loose, and eventually the mobility will start. So mobility will start from grade 1, grade 2, grade 3, and grade 4. And eventually it has to be taken out because then it becomes painful and animal doesn't, like to chew the food or to eat the food. It will throw the food out. So can you see these periapical radiolucencies here? Here also. So the idea is just to see. Now this is a PDL here. So intact, not intact, intact here. Can you see this? Whole of the PDL is intact. Periodontal ligament is intact. So ideally, when you take the X-ray and you watch at the PDL, if you find loss of PDL here, it is being lost. Here it is okay. Here it is okay. Here it is lost. It is lost. So when PDL is lost, you can foresee and you can very well observe and keep in mind that once the PDL is being lost, that means tooth is losing, eventually losing its, its apposition, its placement in the alveolar socket, and consequently it will be loose and has to be taken out. So the equipment's required. You need a scalpel blade, 15 or 15C with handle, then periosteal elevator, high or low speed hand pieces specifically made for the dentistry purpose. Then burrs. I'll tell you what kind of burrs are required. Then dental luxation instruments, periosteal elevators, a rat tooth forceps for holding the soft tissue, then certain materials like suture threads, needle holder, and surgical scissors. One by one, let's cover it. Now this is the Glickman periosteal elevator, and this is also, again, this is also a mold periosteal elevator. This is used to raise the flaps. Can you see this spatula shape? is very fine and sharp also, but not that sharp to, cut the periosteal or the skin flap, sorry, the mucosal flap. Okay, so we use them to, harvest the flaps. Okay, so these are the elevators, and this is the all are the extraction forceps. The lower jaw premolar, then upper jaw premolar, and then the upper molar. You can see the spaces here, and accordingly you can use them as per the requirement. Okay, then the burrs you require is the round burr. So round burr normally required for the alveolectomy or alveoloplasty. I will cover alveolectomy and alveoloplasty, and it also used for smoothing the bones. Now these are the bone files. They can be used for smoothing the bone edges, and these are the cross-cut burr or taper fissure burrs, right? These are used for sectioning the teeth. Two root, root tooth has to be sectioned into two. One root mesial and another is a distal. So you have to cut it from the furcation. For cutting it, you need this taper fissure burr, or we normally call them cross-cut burrs. Now these are luxators. Can you see the shape here? It doesn't have the wings. The one which has the wings here is known as the winged elevator. Now, can you see this? This is the periosteal elevator. It is sharp, but it doesn't have the wings. And this is luxator, and this is elevator, right? It has the wings here. So it goes into the cavity and you can rotate it like this. Okay, so do not confuse between the luxator and the elevators. Many books, they say this as a luxating elevator and this is as a elevator. So just remember that this is the luxator and this is the elevator. Okay. So the luxating elevators, or the luxators have this much of a grip. You can see here, sharp, right? Sharp here. So they can go inside. They are almost razor sharp and a very thin tipped, so that they can be inserted into the periodontal ligament, and with horizontal rocking movement and a pressure towards the apex, you break the fibers of the PDL. So once the PDL is being cut, they get a space to go further. So that means it widens the space by cutting the PDL so that you can insert the luxator instead. Okay, but they get blunt very easily, so they should be sharpened with the sharpening stones. Now these are the winged elevators. Winged elevators. So the luxating elevator or luxator is being used to cut the periodontal ligament. Now this elevator is inserted inside the space being created by the luxator, and it is rotated in different manners so that you break the firm attachment of the tooth with the alveolar socket. Right? So they are thicker, they are more robust, kind of a chisel shape, and you can wrist it, rock it like this, right? And you can slightly use a prying lever. Prying lever means the way you open the jerry can, but don't give much of a pressure. The prying lever is not that much indicated, but sometime it is indicated, but you have to be very, very cautious. Whenever you're doing a prying lever motion, you have to slightly rotate it. So once you start from one tooth, you can go like this, from here, from here, from here. So it becomes like wheel and axle manner. So you go and try to, create or elevate the tooth from the alveolar socket. Right. Now these are the movements here. Now this is the wedge effect by the luxator here. This is, look at this picture here. A beautiful picture. I got it from the veterinary instrumentation. So here the PDL is being cut here. It is being cut with the force which is exerted in a rocking motion and towards the apex of the tooth. So this is the wedge effect. When you slightly do it like this has become prey bar effect. And once you rotate it to elevating, this is known as the rotational effect. Okay. Now, once the space is being created, so you can rotate this elevator inside the cavity and inside the alveolar circuit like wheel and X. Can you see the movement here? I'll show you in the pictures from where I have done, so that you loosen almost whole of the, whole of the attachments of the tooth within the alveolar socket. So once you take it out, then comes the role of the extraction forceps. So once it is being loosened, you can catch hold with the appropriate jaw of the extraction forceps and then slightly you rotate it. So this one is the rotation, right? So whenever you are rotating, you have to give, you rotated it, give a pause of 10 seconds. Let the fibers, they break. Then further rotate it to this side, wait for 10 seconds, let it breaks, let it fatigue. Or you can do a figure of 8. But if you are extracting the canine, please do not rotate it. Otherwise, because the root is large, it can break open the nasal passages. So it has to be taken in a direction where the root of the canine is there. Okay. And once it is being loosened, the traction force is applied to take it out from the alveolar socket. So this is rotation. This is figure of 8 rotation. And this is the traction in the direction of the extraction pathway. Now you have two kind of extractions. One is the simple extraction. Another is the surgical extraction. So simple dental extraction means that you are not using a BP plate. You're not creating a. So in a simple dental extraction, it is performed in a tooth which has a grade 3 mobility, means it is about to come out and has only mild attachment within the alveolar socket, and that can occur in the severe periodontitis. So here only the dental luxator is inserted into the pedial space. The attachment is broken and it is elevated out in a rotatory movement, with a very steady hand for 15 to 20 seconds, and tooth is extracted out. I'll show you the pictures. Now, see here, the grade 3 mobility. Okay, can you see this is a grade 3 mobility here? See, this is the grade 3 mobility here. So it can be easily taken out by inserting the luxator and then elevating it out using a extraction forceps. So you don't need a flap here, right? You don't need a flap here. Just look at this. You don't need a flap here. So it comes out. Okay. So this is not surgical extraction. This is simple extraction. So likewise here also, see here, this is the extraction of the incisor. This is the non-surgical extraction. You are not creating a pipe. Please, some of my videos, they are in a time lapse motion, just to tell you. So don't apply or don't shake the way the video is depicting the hand. They are time lapse motion just to cover the events in the video, but don't shake it like this. Okay. So it is very fast, but you have to be very, very gentle here. Okay. Now look at this. Can you see this is this is without the flap, right? It is inserted inside and you wait for some time and then you take it out. This is the canine which has taken out, in the direction. This is correct. But don't go the other way. It will cut open the nasal passages. Okay. This is specific for the canines. So next is the surgical dental extraction. So whenever you do a surgical dental extraction, don't get scared with that much of a table. I'll just make it very simple for you. The first and foremost thing is give a chlorhexidine rinse to the mouth, right? And remove everything within the mouth, give a chlorhexidine rinse, wait for 5 to 6 minutes, let the chlorhexidine acts within the mouth. Then you do a scaling and polishing, because almost all the tooth which are meant or which are presented to be extracted or loose, they have the periodontal problem. You have to solve the periodontal problem. You have to do the x-rays, and then you decide that what number of the teeth they are tooth they are to be removed from the mouth. So scaling and polishing, then you go for the radiograph of the affected tooth, right? Then you go for the dental nerve blocks in the form of analgesia. Then you give the incision, which is in intrasulcular or circumferential incisions. Flap is created. Once the flap is raised, cut the alveola or alveolus, we call it as alveolectomy. Then once the tooth is exposed, you have to section the tooth. If it is two root tooth or three root tooth, then elevation of each root tooth segment, you have to put the elevator inside, luxator inside first, and then elevator inside, elevate it, and then you extract it with the help of a extraction forceps. Then you do the alveoloplasty. That means the sharp ends on the bony socket, they are to be smoothened, and then you release the periosteum and you suture the flap. Okay, let's make it more simple. So this is the cross-cut bar here. Okay, this is a cross-cut bar here. So this is a dental nerve block. Again, in the fast forward motion, this is the infraorbital block. Some 0.5 ml of it is 0.5 to 0.7. This is the mental nerve block, right? Mental foramen. Okay, and that's the palatine here. Just caudal to the last molar on the upper jaw. Okay. Now you require a blade which is very specific, SM64 beaver blade. If you don't have this, 15 number blade is available to you, right? If you don't have the 15, you can use any blade. But the only idea is, because this much of blade is very strong, very hard, so it creates a very good flap. It gives the initial incision is very good so that you can raise it properly. Okay, so this blade can be used to freshen the gingiva here. Cut it, the margins here. This is the sulcal intersulcal incision here, right? So it is given at the junctional epithelium. So, and with the help of the periosteal elevator, which I showed you earlier, try to create a tunnel here. Okay, undermine the tissue gently, very gently. You should be very, very gentle, especially if it is a cat, because the mucosa is very thin in the cat. So don't just be anxious and don't just rush. You have to be very, very cautious. Okay, so this is how the flap is raised. This is the periosteal flap. Undermine it so you can see the bone here. Okay, so almost all the fibers, they are being extracted from the periosteum here. Okay, so if you for single tooth, this is for all the tooth. If you want to release one, so you can give the incision over here, right? So cut it and you can do an anvil flap. For single rooted tooth, you need not to give two incisions. You can simply cut the junctional epithelium and undermine it. You will create a kind of a curtain over there. Remove it and again replace it. But like if it is a canine, you have to give incision here so that whatever you create, it becomes like a triangle. So this is a mesial surface here, right? And you give one incision on the mesial surface and incision here and try to reflect the flap in a triangular portion. Okay. Now this one is a pedicle flap. So you give incision here, incision here, incision here, and the incision here, and try to remove or reflect, undermine whole of. We do this especially when we are doing additional release, or when we are going for a full mouth extraction, or the 2 or 3 teeth, they are together and all of them are to be removed. Then you can go for the pedicle flap here, incision here, and incision here, and reflected. Just see here. This is the lower first molar, right? So almost a triangular flap here. Now this is the maxillary canine here, okay? And this is the mandibular canine. So alveolar is visible now. So now you have this alveolar socket here. So next step is so just to tell you that, the triangular periosteal flaps, they are preferred because they are released only with the one single. And if you are releasing more of the tissue, you can always expect a gingival recession. Okay, so don't cut too much of the tissue and don't give a wider incisions. Let it be a triangular one. You can manipulate accordingly, but larger the release is, more the gingival recession is in the later stages when it heals. Okay. So just see here, this is a cat. The incision is given. So the other incision is given on the side. The flap is released. So look how gently you can use the periosteal elevator and very gently try to first, undermine the flap very gently, go towards the other side, release it gently, right? With a twisting motion, right? Don't thrust towards the apex side. You have to be very gentle and twisting. Okay. And have patience while you make, because this periosteal flap or health of this periosteal flap would be very important when you're going to close the defect or close the wound. Okay. Then, since you have raised this flap here, okay, now this flap is being raised, you have the alveolar bone here. Now you have to do the alveolectomy. Look at this. With the help of a round burr, you are doing the alveolectomy. You are cutting the alveolar bone to expose the root of the tooth here. Okay. So you can use 4 to 6 round burr, and for the cat, you can use 2 burr, especially for cutting it, and lower the burr for the margination here. So ideal principle is that you have to cut the alveolar bone 50 to 60% of its root, So 50 to 60% of the root of the tooth should be exposed. That much of the alveolar bone has to be cut. Okay. You have to avoid the sharp corners to bone removal. Okay. If you are cutting the alveola and within 3 to 5 minutes, you don't find any movement, any loosening of the tooth, cut more alveola. Okay. If you start finding the tooth is loosening, or the alveola is freeing the tooth, then you stop and you can use the luxation then. Okay. See here. Okay. So can you see this? How beautifully a round margin of tooth is exposed here. Right. Now you have this much of the root exposed here, right? So with the lower burr, if you have done it with number 4, with the lower burr, you can work on the margins here. So margins can also be released here. This is also a very round one, right? So try to create a round or a curved sharp edges when you want to release a tooth. See here, just a skull to demonstrate how the direction of the canine is there. The premolar is there. This is the carnassial tooth here, tree root. Okay, how they looks like. So once it is being released, this is the reflection of the mucoparietal flap here. Okay, this is a sectioned teeth. Now, what happens is that sometime the tooth has a very close association with the proximal one and a caudal one. Okay, like this. This tooth is very close to this tooth, and there is hardly any space to insert the luxator inside. So you have to cut this cusp. This cusp has to be cut either here or here. If this is touching, then here. If this is touching, then here. So once you cut the cusp, you create a space like it is being created here. From here, the luxator can be inserted inside. Now, this whole process is known as coronoplasty. You have cut this much of the crown here, this much of the crown here, to create a space for the periosteal, so for the dental luxator to go inside the root or go inside the periodontal ligament space. Otherwise, if you keep on struggling from here, this tooth, either this one or this one is going to break, or the root is going to break. Okay, so this is a strategic removal of the crown to have a straight line access to the periodontal ligament. So you begin sectioning the furcation area here. See, this is how one root, two root, or three root, it is separated. So you remove the roots accordingly. I'll develop it further. Don't worry. See. So you're going to hold is like this. Why tip here? Why tip here? Because if you hold it like this and you're going like this, it will end up in the infraorbital foramen or can end up into the nasal passage. So protect it. This has to be like this, has to be like this. Hold it from the palm and keep your finger here, right? That much of the space is to be only given. Then you can apply the force. If you are holding it like this, the moment it will break the periodontal ligament will go inside, it will be thrusted inside. Okay. And don't try to apply that much of a prying pressure. Very little pressure. Avoid such kind of the prying forces. Okay. Let's talk of the sectioning of the multi-rooted tooth. Okay, let's talk about the 309 and 409. So here is the 309 and 409. It has two roots here. So the tooth has one root, distal, the mesial and the distal root. Okay. Now this is the coronoplasty incision here, which I was talking about. Okay. So you can either cut it from the furcation and take it out, or you can cut the cusp in a triangular portion like this. You can cut the portion, a triangular portion like this. So once it is cut up to the furcation, this root is separate and this root is separate. And within the space, you can insert the luxator and luxate it out and elevate it out properly, right? Not a good idea to try and take both the root in a single go. It won't come. Okay. Now, this is the mandibular second molar root. So this is how a furcation is, is cut section, and the mesial, that means the one which is a proximal, is root is taken out first and distal later. When you talk of two-rooted premolar tooth, the distal root has to be removed first. Okay. When you talk of the first mandibular molar tooth, the distal root has to be extracted first. Okay. Remember this. Remember this. Now, this is sectioning of the three roots. That is 109 and 209 here. The molars here. They have, look at the shape here. One root, two root, and three root. Okay. One root, two root, and the third root here. So you give incision like this. First of all, separate the two roots, right? And then from here, the third root is being separated. Okay. So the tooth is like this. The tooth is like this, it is like this. So one root you separate it from here. So these two roots, they can separate the mesial and the distal, and this coronal is again separated and taken out. I may be having the video here. So this is how it looks like, from here. from here and from here. This is from the lateral view. Okay, this is for the maxillary fourth premolar tooth. This is sectioning of 108 and 100 and 208. These are three roots. 1, 2, and this is coronoplasty, and the third root, right? So you have the mesial root, you have the distal root, and the palatal root. So these three roots are to be taken out. So this is the gingiva canine tooth extraction. So in the canine, you have a single root. Canine is the biggest teeth, and until and unless it is much affected, it cannot be easily taken out. You have to do a good bit of the alveolectomy here. So initial incisional gingival flap is being made here, cut it, and then you release, elevate the flap, right? And then high-speed burr is used to remove the alveolar bone. Then you use the dental luxators here, smoothen the edges, and you close the flap. Okay, I'll talk about the clinical cases later, but this is how it is being taken out. Okay, so here you are dividing the root into two, taking the one root out, the other root out, and then you are doing the contouring and smoothing, and you are closing the site. Now, use of luxator and the elevator here. Look at this picture here. So this is how the luxator is inserted inside, and the tooth is being loosened here. Okay. So this is the sectioned root. So one root is being taken out here. Now, how to use the elevator? Now, can you see here the 1, 2, and 3 roots here? The one is taken out. Okay. The other like this. This is again the fast forward. Don't do it like that. Be gentle. See, from all the angles in a rotatory motion, it has to be taken out. Okay. So here I'm using the elevator to take it out and using the luxator to luxate the PDL. Now, once the tooth is taken out or extracted out, how to know that you have taken a full tooth out or the part of root has remained inside? Because sometimes due to undue pressure, it happens with me also. Sometimes the tip of the root, it remains inside, then it has to be taken out. Okay, now look at this picture and observe something. So this is the loosened tooth. I'm taking it out. Once it is being taken out, see, I am rubbing it with my hand. Again, see it. And just go back. Rub it with the hand. Did you see that? Rubbing with the hand here. Rubbing on the back of the hand here. So if you find that this rubbing is rough, that means the tooth has fractured and part of the root has remained inside. If it is very smooth and glides okay on your glove back of the hand, that means whole of the root has been taken out. So this is the extraction check you normally should do with all the teeth. Now you have to close the wound flap. See, ideally, whether you are doing a surgical extraction or you're doing a simple extraction, flush the things and then suture it. Okay, put the animal on the antibiotics. Literature says that all the wounds, all the sockets which are being created either by the simple extraction or by the surgical extraction, they are to be flushed and they are to be sutured. The wound has to be closed. Okay, so prior to closing the alveolus, you should debride the granulation tissue and the diseased bone, right? Gently irrigate with the distilled water without the air. Don't give much of the air because do not lose the blood clot from the socket. If you lose the blood clot, we call it as a dry socket, and dry sockets are very, very painful in humans also, although not much study has been done in dogs, but don't leave the socket dry like anything. Some of the blood clot should always be there, and then you close it, because wound closer, whether it is bleeding, once you close it, you put some hemosponge inside, close it. As a tamponade pressure, the bleeding stops. It stops. But don't give too much of the hawa, too much of the air to the alveolar socket. Don't just leave it dry. That is one tip regarding closure of the wound flap. So you need uh, 4-0 or 5-0. In larger dogs, we are using 3-0 or 2-0 also, right? So the ideal is that when you are closing the flap, the bite should be taken 3 mm away from the edge. Okay, in the both the sides, 3 mm away. Monofilament, polygaprone, right? With the reverse cutting needle. With the taper cut needle, it is very difficult. It takes a lot of pressure. The flap can break. Okay, but leave only 3 mm of the tail of the suture. Very short tail of the suture should be left behind. Otherwise, if a large tail is left behind, then with the help of the tongue, animal will open with the help of the tongue, the constant movement of the tongue, animal can open the knot of the suture being applied. So leave a 3 mm or a very small tail of the suture, cut rest of the tail. Okay, just look at this again in a fast forward motion here. So this flap is being slightly undermined to make it slightly more comfortable. I don't prefer stretched, this thing. So this is the monocryl we are applying here. Close it. This is how it has to be closed. So try to loosen the the flap so that there should not be any pressure, because if pressure is there and the alveolar prominences can break the flap open. So be and try to give don't use the continuous flaps, continuous sutures, individual knots. If you applying the continuous, once the one knot opens, whole of the suture line is then becomes unstable. Now, this is the surgical extraction of all the teeth behind the canine. So this is canine, and these whole tooth are to be removed. Okay, why? Because the dog has an issue. See, the furcation has exposed, their mobility is there, animal is not able to eat. So we are doing an initial examination, right? And go for the radiograph here. Then incision is being given, right? Gingival incision. It is being extended into the intercircular incision here. Then you raise the flap here, and then you do the alveolectomy here over the roots, expose the root. 50 to 60% of the root is exposed prior to putting the luxator inside. Now, this is sectioning of the tooth here. Now, this is with the cross-cut bar. I'm cutting the furcation here. Look at again here, cutting the asparagus. So two roots, they are being differentiated. So here also I'm working on the margins of the alveola. It's a larger tooth, so margins of the alveola is being cleared off so that you can put the luxator inside. Okay, so this is how the luxator is being placed here inside. So this is how you wait for 20 to 30 seconds, right? Don't just let it displace from its own. Here also, see, once it is being removed, and with the very gentle motion, take it out, and can always check on your hand whether the root of the tooth is taken out or not. So that is the sectioning of 108. Okay, this is 108 sectioning. See here. So that is the 1 and 2 root are separate, and the third root is being separated here. So again, see. So this is how it is being sectioned. It becomes so easy when you section the tooth, because then it becomes a very unstable structure and can give you a space to insert the luxator inside and elevate it properly. See here, placing the luxator in the furcation which has been sectioned here. And this is how, see, it is being cut. So the tooth is taken out easily, right? So once you take the tooth, look at the alveolar edges. They are very sharp. So once the flap comes over it, the sharp edges can pierce the, look at these edges here, sharp, very edges sharp is there. So just make the flap more ready. You can create a loose flap, right? And sharpen it properly, and then you can close it with the sutures. So this is again a case. Initial presentation of the case is like this. Then scaling and rinsing with the chlorhexidine solution. So then the gingival and sulcal incision is being given here. Cut it like this. Okay. You raise the mucoperiosteal flap very gently, and then you section the tooth, cut the tooth from here. Then alveoloplasty. Now this is the alveoloplasty we are doing here to smoothen the edges of the alveola, right? Then release the periosteal flap here slightly, undermine it, and then it is being sutured here. Can you see the sutures here? So now this is regarding the, the extractions of the tooth. Principle is one: single root tooth, no sectioning, two root, section it, three root, section it. All the roots are to be taken out separately. Now, can you see this X-ray? There can be some intraoperative challenges here. Okay. So when there is intraoperative challenges, this is a part of the tooth has been taken out. The tooth has been taken out, but the half of the root is inserted, has remained here, because the fracture has occurred. And these fracture, they can occur of the many reasons, because of the inadvertent force applied, or you want to have a kind of, you want to open a lid like this thing. So all inadvertent pressures can cause the fracture of the root tooth here, right? So take a radiograph after the extraction, right? Then if it is a simple extraction, convert into a surgical extraction. Now you have to cut it. You have to cut the alveola over it. So again, alveolectomy has to be made, and a kind of a gutter is being created here to expose the tooth here. Now the difference would be known to you once you try to dissect it out. If it is a white bone color, then it is the periosteum. It is ivory color, it is the tooth. So you have to see the margination of the tooth along with the alveola, and then again with the help of the luxators and the elevators, take it out. Right. Now, some of the complications are the neuromuscular trauma here. Now, all the neuromuscular traumas, they occur because of the inadvertent use of the elevators here. When you give a pressure, it cuts open the apical surface, apical region of the tooth, and goes inside into the infraorbital foramen, into the mandibular canal in the lower jaw, or into the nasal passages in the upper jaw. And thus, such kind of oronasal fistula, they are being created, right? It can go into the infraorbital foramen also. So it can lead to cellulitis, it can lead to a globe penetration, sometimes the eye penetration, leading to the panophthalmitis, oronasal fistula, and sometimes the brain penetration. So when we are applying too much of a force. Okay, just see here. See here. Okay. Can you see the tooth here? Can you see the tooth here? This is the tooth here. root here, and this is the infraorbital foramen here, canal here. Okay, so if you apply a lot of pressure, it can go inside. See here, can you see this tooth here? Here is a tooth like this, right? So this is the first molar tooth close to the mandibular canal here. So extra pressure will end up in the mandibular canal. So be gentle on it. Okay, some of the preventions, how to do it. See, the second maxillary molar here, the extraction should be very, very careful. It is a high risk area because if you poke the instruments more, it can end up in the nasal passages, creating a oronasal fistula. Okay, so you have to minimize the apically directed forces. Apically means the forces towards the apex of the tooth, towards the root tooth. Okay, especially if you find that such kind of the apical diseases is there. You can see a large cystic structure over here. Okay, then the biggest thing is your holding of the elevating forceps, sorry, elevating or the elevators here, help with the help of a palm. Okay, then appropriate angulation and use the sharp instruments. Sharp instruments, they cut with a low pressure or with a minimum pressure. If they are, blunt, you will end up giving more pressure. When you give more pressure, that means you lose control over it, right? Then with the dominant, non-dominant hand, try to, hold the jaw also. You have to hold the jaw also. Okay. And don't let it free, because if it is free, then you can definitely end up giving more of a pressure if hemorrhages are there. So hemorrhages, they do occur. Hemorrhages, they do occur. So simple pressure application you can do. If you see a bleeding vessel, you can ligate it. You can use a, what do you call, the cautery also, right? But if large diffuse bleeding is there, my favorite is the hemosponge. I cut this hemosponge, put it into the socket, right? It soaks the blood, act as a collagen scaffold there, and then suture, do a wound closure. Okay, and you can use a tranexamic acid preoperatively also, just to avoid the hemorrhages. So hemosponge works well where there is a diffuse bleeding, socket is large, cut it, put it inside, and resuture the flap. So you control the hemorrhage. Jaw fracture is very common in a case where you want to extract the lower canines. Look at this is the mandibular symphysis here. Look at the root of the lower canine very close to the mandibular symphysis, especially if it is a puppy or a cat. You've got to be very, very gentle here. Otherwise, a little bit of pressure can break it and cause the fracture of the pelvic, the mandibular symphysis. And then you have to do a wiring over here. Now, this fracture can also occur. This has also occurred while the extraction of these tooth, right? But it can be fixed. Then, it can be fixed. So very common during the extraction of the mandibular canine, this one, and the fourth premolar and the first molar. So those teeth are, more prone, which have very delicate mandibles like brachies. Okay, and where there is a severe horizontal and vertical bone loss and there is a severe periodontitis. The only way to prevent the jaw fracture is to catch hold of the jaw with a non-dominant hand and you're working with the dominant hand. Okay. Surgical extractions are more controlled. If you're doing a simple extraction, it is not controlled. Surgical extraction, you see the tissue, you see the tooth, you see the root, so you know how much deep you're going inside. Okay. Avoid extreme buccal tipping. Don't try to, take it out, take the things out. Eventually it will come, but it will come with your patience. Now, to close the talk, I must say that the dental extractions are a vital interventions for the dogs and cats suffering from the advanced dental diseases. And I tell you that, I've seen a very depressed dogs coming to the hospital, owner saying that it has lost the demeanor, the playfulness. I've done even the full mouth extractions. I've seen these guys turning gentlemen and become more athletic after the extractions. It alleviate the pain, it prevent further health complications, and it significantly enhance the pet's well-being and the longevity also. But the dental extractions in dogs and cats are the surgical procedures that demand a very methodical approach. Appropriate technique selection should be there. Then the skilled use of the instrument should be there. You should be knowing the anatomy on the region you are working, so that to ensure the effective, safe, and minimally traumatic outcomes for the patient. It is not a tough job. It is an easy job. Try, do a little bit of mistakes, and then learn. Thank you so much.
Questions? There is a chat box, sir.
All right,
if you
I'm
can
just
access the
coming
chat
here.
box.
Okay,
Yes,
fine.
sir.
Yeah, what are the possible complications of the retained tooth? See, what happens is that if it is a retained tooth, mostly it is a deciduous tooth. So what happens is that the root of the deciduous tooth impinges upon the tooth root of the permanent tooth, right? If it is a small breed, doesn't matter, but with the passage of time, once the wear and tear or attrition of the tooth start, this root impinges upon the root of the permanent tooth and can cause injury and can loosen the tooth. Okay, so it has to be removed out. Just to imagine that you have one cavity to accommodate one root, and that cavity has two things, so one has to be taken out. Okay, so extractions. So what are the extractions can we do in general anesthesia? Because yes, you can do it in the general anesthesia. If gas is not available, you can put the animal on the CRI. You can do the incremental IV anesthesia if you don't have the inhalant anesthesia. Anil is asking that how to manage a broken tooth when extractions. I say broken tooth is quite a good problem. I told you you have to dissect the alveolar. Okay, dissect the alveolar, right? If it is, since you have to take an X-ray, okay, take the X-ray, see the size of the root tooth. If very small tip is, has remained inside, literature says doesn't matter, it won't cause any harm. But if some vital structure has left inside and sizable amount of the root is inside, dissect the alveolar, cut the alveolar, take it out. Or what normally sometime I do, if I find a very small tissue has remained inside, I put a round burr inside and I give a rotation inside, right? And I try to shave off the internal cavity of the alveolar. Along with that, scoop the things out, scoop the tissue out. So Dr. Nehru is there. Okay, fine. Where can we get these instruments? So, well, if you want specific veterinary dental instruments, you can go to IM3. They are available here, but you can use the human ones also. So what are carnassial tooth? See, carnassial tooth has three roots. Originally, carnassial tooth in the cavity, upper one or low one, they are there to tear off the loaf of the meat. Okay, if you go abroad, people get these carnassial tooth removed as an elective surgery. Okay, so in journal examination, what happens is that, what are their role for us in journal? See, you have to see because it has a bit of a cusp, has a three roots. Okay, so सबसे ज्यादा जो calculus है वो इसके ऊपर. Okay, because all the tooth, they have a triangular cusp. It has a bit of a cusp which is flat. Okay, so doesn't matter much but you always see that it is the biggest tooth inside, has a 3 root, and periodontal issues are more in the carnassial tooth. So generally gums in the pus we remove, but again gums filled with the fluid inside. See, if gum has a pus, that means that there can be the apical abscess. So you are removing the pus, again the pocket of pus is being reorganizing and the pus is coming out. So dear friend, please take the x-ray of this animal, a tooth x-ray, right? Try to locate the abscess. If it is there, take the tooth out and then drain the abscess. Okay, so mostly it can be the periapical abscess. So if x-ray machine are available, dental surgery are possible, like doing or not, because many times if x-ray machine, see, x-ray machine is must, I tell you now, the very small x-ray machines are available. They are DR ones. So it is always better to have the x-ray machines if you are doing it. If you don't have, still you can do it. Doesn't matter, right? But don't go for very complex extractions, okay, where the chances of it should be very technically sound if you are not using the x-rays. So scaling next is Dr. Nehru. Scaling in pets after 2 year or 3 year, should we do? Nehru साहब, good evening. आप नेहरू साहब साल में 2 बार कर लीजिए. Okay, you can do it in twice. At least examine the oral cavity twice in a year, and if you find that, see, every dog who is more than 5 years of age is 80% susceptible to the periodontal issues, out of which the calculus is very common, and especially if the animal is purely on the commercial food, powdered food. Okay, so at least twice a year cleaning should be there. Sir, how to proceed? Nikita is asking how to proceed with overgrown canines in dogs. Is extraction the only option? No. See, if it is an overgrown canine, I always see the occlusion. If the occlusion is creating the injury, I will do a crown amputation. I will not extract it. I will do a crown amputation and will do a oral restoration. So I will cover the oral restoration is my last lecture. In the last webinar, we will cover how to do a crown amputation and how to do a restoration of the tooth. That's a very nice question, Nikita. So hook on to the 4th webinar. I'll let you know how the overgrown canines are to be dealt with. So Hamid is asking what can be done in case of malocclusion in small animals or rabbits, especially. See, I'm not expert in the rabbits, I tell you. I don't have that much of the exposure in the rabbits. I'm oftenly getting the elongated tooth. I'm simply cutting it. Rabbit dentistry is completely different branch. Okay, so rabbit is one thing which we are looking in future also. But what can be done in case of the malocclusion? See, it is a very generalized term, malocclusion. Malocclusion can be of many types, lingoversion, labioversion. What kind of malocclusion is there? According to the malocclusion, the treatment has to be decided. But let us make it very clear, if it is a sow mouth or if it is a parrot mouth, it cannot be treated. Okay. So X-ray machines are not, oh, it is available. I'm using a woodpecker machine here. It is available. It is available. Hamid is asking, sorry, Das, what are the precautions can be taken with diet post-op? Yeah, diet should be a very soft diet initially for 7 to 10 days. Okay. Do not give bones. I mean, do not give a very hard diet. Try to moisturize the diet. And I tell you, my experience is that the oral wounds, they heal very quickly until and unless the animal is immunogenically compromised. If animal is immuno-incompetent, then only the oral wounds or oral lesions, they create a problem. Otherwise, with a healthy animal and a very good the antibiotic cover and the inflammatory cover, the wounds they heal very nicely. So Shashank is asking how can we manage the complications like oronasal fistula formation. So Shashank, you to go to my webinar number 2. I think Dr. Vishal might be uploading it. So it is a huge thing. You have to create a flap, debride it, and that flap has to be taken over. So I've covered the oronasal fistula in the second webinar. X-ray machine is very cheap, Nehru is saying, okay. What can be
Actually,
done in
Dr. Hamisha question is repeating again and again, maybe some typing.
but that's
Yeah.
What can we do in the enamel resorption in dogs? See, enamel resorption can occur. It is also a very common. So once the enamel is being resorbed, that means that the dentine is exposed. Now, if dentine is exposed, that means the animal is feeling some kind of a pain. So what we are doing is that if it is on the tip, we are removing, we're doing the crown amputation and restoring it. Otherwise, this animal cannot be restored. Okay, I'm sorry, animal doesn't grow. But then freshen the area and you can restore it with the help of a composite. Okay, I'm going to cover this in the next webinar. Sumit is asking, can it be possible to remove maxillary incision in case of brachianism or for correction? I didn't get. Can it be possible to remove the maxillary incision? Maxillary incision means this is not much clear to me what you want to ask actually. Okay, you can specifically send a mail to me if you're. So I'm not maxillary incision is not getting you. So he's asking, please share the video of some typical removal. Incisor tooth can be taken out in a, if they are loose and grade 3 mobility is there, you can simply luxate it and you can extract it by simple extraction. You don't have to go for the surgical extraction. Okay. Especially all the maxilla and mandibular both. They can be taken out with the help of the luxator in the elevator. You don't have to do, but try to close the socket which has been there. So that's all, I think, Dr. Vishal. I'm not getting more questions.
Yes, sir. I think we have covered almost all the questions. And I think this is the time to say goodbye, sir.
Thank you so much.
On behalf of Oriheal Lifesciences and entire team, I extend my heartfelt thanks to all the esteemed veterinarians who joined us for the webinar 3 of our ongoing series, Solving Orodental Challenges in Small Animals. We are especially grateful to Dr. Adarsh Kumar for his highly insightful and practical session on tooth extraction in small animals, indications, instrumentations, and step-by-step procedures. Your expertise is clear guidance on such a critical aspect of small animal practice added immense value to the learning of every participant, sir. We deeply appreciate the active participation and continuous encouragement from the veterinary community, which motivates us to keep bringing more relevant knowledge-driven session for clinical advancement. We will be expecting the next session soon, sir. Thank you so much for your time, trust, and continued support, sir. Thank you so much.
Sure. Thank you so much. Thank you so much. Thank you, everyone.
Most trusted pharmaceutical company for companion animals of the year goes to Oriheal Lifesciences Pvt Limited, Dr. Vishal Sharma from Oriheal Lifesciences Pvt Limited.